Thank you very much for the invitation to participate in this 20th annual conference of Women Cancer Initiative in the Tata Memorial Hospital. Thanks a lot to the organizers for the invitation. And the title of my talk is Pathology of Clear Cell and Mucinous Carcinoma. Just let me start by putting emphasis in the fact that ovarian cancer is heterogeneous, that we have 5 different tumors with different risk factors, precursor lesions, pattern of spread, molecular abnormalities, chemosensitivity, prognosis, and molecular features, and morphologic features. And we have high-grade serous carcinoma, of course, the most frequent type, low-grade serous carcinoma, endometrial carcinoma, and the 2 tumors that we will comment today. So let's start with clear cell carcinoma, which is a tumor defined by WHO as a malignant tumor composed of clear, eosinophilic, and hobnail cells with tubulocystic, papillary, and solid architecture. It's a tumor that is unilateral, accounts for 10% of ovarian cancers, is usually diagnosed at early stages associated with endometriosis, and particularly when it is diagnosed in advanced stage, is less likely to respond to platinum-based chemotherapy. The tumor is cystic and solid, occasionally coexisting with an endometrioid cyst, tubulocystic, complex papillae, clear hobnail oxyphilic cells with hyaline basement membrane and hyaline bodies. These are 2 typical gross pictures. In one is this solidocystic appearance, and here this is a bulky tumor in a cyst that was originally filled with blood. So that was a node endometrioid cyst, and the bulky tumor was a clear cell carcinoma. And the morphology. Papillary, as you see, this papillae with hyalinized core, cystic with this mucin content, and the solid with clear cells. There's several other features that can be helpful in difficult cases. For example, this is a tumor that you sometimes have this demarcated zonal necrosis. This is quite typical of this type of tumor. And also the presence of this myxohyaline stromal change that sometimes raise problems in differential diagnosis and has a prognostic importance. The immunohistochemical features of this tumor are characterized by negativity for WT1, usually negativity for estrogen receptor, usually wild-type pattern for p53, and positivity for hepatocyte nuclear factor 1 beta, napsin A, and racemase. An event that is sometimes occurring and has importance in prognosis is the development of a somatic germ cell component in a clear cell carcinoma in the form of yolk sac elements, particularly with enteric differentiation, these typical subnuclear vacuoles. And that's important because the presence of these vacuoles is sometimes interpreted just as a pattern of clear cell carcinoma. This is not. You have, of course, demonstrated that this is germ cell aldosomatic by immunostaining, and this is important from the prognosis viewpoint. Differential diagnosis of clear cell carcinoma is broad, but because I don't have too much time, I'm going to focus on high-grade serous carcinoma that after neoadjuvant therapy can have this prominent clear cell raising problems in differential diagnosis. This is a case in point. You see the tumor has clear cells, but it's negative for napsin A, for racemase, and strongly positive for WT1 estrogen receptor, and has a mutated pattern for p53. The molecular features of clear cell carcinoma are somewhat similar to endometrial carcinoma, the tumors that arise on endometriosis, but added 1A is the most frequent, most characteristic alterations, and that was described by the group of Vancouver many years ago, when you can demonstrate the presence of ARID1A by immunohistochemistry by demonstrating loss of expression of the protein. This is a tumor that has frequently mutations in homologous recombination repair genes, so that's one reason why this tumor is not responding to chemotherapy. And it's a setting in which we can use the molecular classification that has been proposed in endometrial carcinoma. As you know, in endometrial carcinoma, we're using that based on the TCGA, who identified 4 subgroups, molecular subgroups of endometrial cancer. One group with very good prognosis, polymutated tumors. One group with very bad prognosis, p53 abnormal. And 2 groups with intermediate prognosis, the so-called tumors with microsatellite instability and the so-called tumors with non-specific molecular profile. And we can do that just by performing one molecular test, polymutation, and immunohistochemistry for p53 and mismatch repair genes. So there is evidence in the literature that this can be applicable to endometrial carcinoma, also to clear cell carcinoma, and this is just a recent paper emphasizing that. The problem is that the vast majority of clear cell carcinomas are non-specific molecular profile, but when there is a tumor which is polymutated or mismatch repair deficiency, the prognosis is very good, and when the tumor is p53 abnormal, the prognosis is very bad. So this is a scenario in which we can use this molecular classification. And in terms of precision medicine, this has not reached the clinical practice, but ARID1A is an opportunity for treatment because ARID1A is related to immune checkpoint inhibition. It's related to PARP inhibition. So since 50% of the tumors are ARID1A negative, there are possibilities of treatment. So the second tumor that I would like to touch is mucinous carcinoma. And this is an invasive mucinous neoplasm composed of gastrointestinal type cells. This is unusual, 3% of ovarian cancer, but the most common subtypes in young patients. Up to 80% are diagnosed in early stage, but advanced stage is associated with bad prognosis, and differential diagnosis is challenging with metastatic tumors. Very important, and that is different from other types of tumors in the ovary. When we have a mucinous carcinoma, we can have areas of borderline or benign tumor. So there is a spectrum of changes. And you can see, we can demonstrate that the spectrum of changes if we pay attention to borderline tumors. In borderline tumors, we can have intraepithelial carcinoma, we can have microinvasive, or even we can have microinvasive mucinous carcinoma. So these features demonstrate that there is a spectrum of changes from borderline to mucinous carcinoma. And sometimes in the same field, in the same microscopic field, we can have benign glands, borderline, and malignant here by this cruciform pattern. So from the pathological viewpoint, the tumor is composed of gastrointestinal type cells. As mentioned before, it may have benign and borderline components. There are papillary cribriform areas, and the growth can be expansile, confluent, or infiltrative. And immunohistochemistry is not quite definitory. It's positive for CK7, sometimes positive for intestinal markers, and negative for estrogen and progesterone. So this is typical growth and microscopic appearance of a mucinous carcinoma. And very important to distinguish between this confluent glandular expansile pattern or the destructive pattern. There are many evidences showing that these two patterns have different prognosis, and there is a recent paper showing that not only is the presence of infiltrative pattern, but the percentage of infiltrative pattern. In that paper, an infiltrative growth in more than 10% of cells was prognostically relevant. Talking about molecular features, this is an old paper from our group. The first author was Miriam Cuatrecasas, demonstrating that KRAS was frequently mutated in any type of mucinous tumors. And there are many others papers showing the landscape by next-generation sequencing. I have just selected 2 of them, showing that KRAS is still the most frequent abnormal gene, that there is a subset of tumors that have p53 abnormalities, and then HER2 is also frequently amplified in this tumor. This is another paper emphasizing the fact that KRAS mutations and HER2 amplification can sometimes be mutually exclusive, but sometimes can coexist. And I don't have time to go into that, but there are many other papers showing that mucinous carcinoma has a complex genotype, which is different from what is seen in metastatic tumors, and that may lead to molecular pathology, the usefulness of molecular pathology in this differential diagnosis. Because I will finish with that, with the differential diagnosis of mucinous tumors. And this is really challenging for pathologists. Of course, any type of mucinous carcinoma of the colon, of the stomach, of the uterine cervix can mimic primary mucinous tumors. But I will focus, because of the limitation of time, I will focus on tumors from the appendix and tumors of the pancreas, which, in my opinion, are the most challenging. So metastatic appendiceal tumors can mimic not only malignant, but also borderline tumors. In the past, the presence of mucinous tumors of the appendix and mucinous tumors of the ovary were regarded as 2 independent primary tumors, not longer. It's clear now that the appendix is the primary tumor and the ovary is the metastasis. They have pseudomyxoma ovary, and peritoneae, they have thick mucin, they have abundant mucinous cytoplasm, hypersecretory, lifting of the epithelium from the underlying stroma. And then just a word of caution, because sometimes primary mucinous tumors of the ovary are associated with dermoid cyst. And when that happens, they are really very similar, almost indistinguishable from metastatic tumors of the appendix. So this is something to remember. So this is just an example of this, an appendiceal primary tumor, and how metastasis was composed of cells that were look benign or borderline. The hypersecretory appearance, lifting of the epithelium in comparison with the stroma. These are helpful features in differential diagnosis. Metastatic pancreatic and biliary tract carcinomas, I put these two tumors together, although there are several differences, but they raise problems with differential diagnosis. They can mimic mucinous primary tumors. They have benign looking areas, and they have dysplasia. And they may resemble primary tumors, even benign or borderline tumors. And immunohistochemistry is not that helpful, although DPC4 is useful in 50% of cases of pancreatic metastasis. And these are examples. But I remember one challenging case when I was in Boston with Dr. Scully, a tumor that I misinterpreted as a benign cystoadenoma. There were just small foci of dysplasia in the stroma, and it was a metastasis. So this is really a challenging situation. So thank you very much for your attention. This is the end of my talk, and I'm going to be happy to take any questions. Thanks a lot.